Good morning, everybody. Welcome to Tales from the Heart at 11:10 a.m. on May 2nd, 2025. There are reasons that I give dates and times at the start of our sessions. And today it's because there's been some late breaking news that we had to do some very quick research on before we came live. Today, I am happy to be joined by Dr. Michael Ayers from UVA. Good morning, Michael.
Good morning.
How are we today?
So good. It's
So good. And we have a
beautiful.
puppy in the background. So if anybody sees the puppy moving in the background, we like dogs. So we don't always have to have the fancy studios. We like casual too. So this morning, I have a couple of announcements that I want to begin with. And then we're going to talk about some late breaking news, which is coming to us from our friends at Cytokinetics. So as we get ready to start this session today, I just want to make sure that we're shared over to the Facebook group. Ross, is that done? So that I can put the shout out into that community as well. I'm looking for a nod from the back end. Okay. So we have some news from some of our big-hearted friends out there that are in the midst of some challenges. And I don't normally start off with personal call-outs, but we have two. Last weekend, our team was in Orlando at Advent Health. Shout out to everybody who participated in the event. But we were able to stop at Advent Health and visit one of our HCM warriors who was in the hospital waiting for his transplant. He's been listed for over a year. And I made a little joke that, I'm coming to town, so your heart's got to be coming too. Little did I know that the very next morning they would get an offer for a heart while we were actually in the meeting. So that heart got accepted. It took a couple of days for everything to get moved into place. So Tuesday morning was the actual transplant, and he is in recovery right now, but he's having a rough time waking up. This is not uncommon in a transplant situation, and I know many of you who follow us online see us cheering for a transplant warrior, and then you, a couple weeks later, might see their photo and everything went well. The first few days and hours after transplant are very, very tricky, and there's a lot of stress and there's a lot on the line. And right now, Brian, he's struggling a little bit. So let's give him some positive thoughts, prayers. He's a very religious individual. He would appreciate your prayers and good wishes. And he's stable at the moment, but he's not out of the woods yet. And when you hear transplant, I'm 8 years out. I look like a normal person. Everything's fine now. But it doesn't always go that way. And we need to make sure that we're focusing on the whole journey, not just that moment of, yay, he's got an offer. Now the real work starts. And it's going to be weeks until we know how well he's going to do. So please send your thoughts and prayers out to Brian, his wife, Cassie, and all their friends and family. And then in another turn of events in our transplant community, one of my very first clients was a young lady named Esther. She was 8 years old when I first met her. Life went on. I lost track of her for a while. And then another young lady and a mother of two named Esther calls me up and says, I have HCM since I'm 8. And I'm like, was your maiden name this? And she said, yes. I'm like, I know all about you. She went on to have a transplant a number of years ago while she was living in Long Island. And when she moved to Indiana, that heart failed and she took a second heart transplant. Well, I'm sorry to say today that she's been transferred to Vanderbilt, where she's being evaluated for a third heart transplant. Her children are in their early teen years, 12, 13 years old. She's a young mom who needs another heart transplant to be here for her kids. So we will be working with the family. They need to raise funds because this is an out-of-state transplant and she doesn't have any other options. So I know they've raised a little bit of money on their GoFundMe already. We'll be posting that on our Facebook group later today if you wanted to support that. We don't often support crowd-funded efforts, but we've known Esther her whole life, and she needs a little help getting over the finish line here. So we will be sharing that. So those are the not so great updates from our patient community, although optimistic that there is healing available for them. There are treatment options available for them, and how important those treatment options are. So those are from the community updates today. And now we have the bigger community, the more ecosystem community. There was published this morning that Cytokinetics has received notification from the FDA that their PDUFA date, which is the date that the FDA has told them we will be giving you an answer to your request to sell your drug. That PDUFA date was originally set for September, and they pushed it back to December. Now, the minute you hear pushback in FDA, 1,000 little bells go off in your head, as I'm sure they did for Dr. Ayers, like, why? What happened? What's going on? So, of course, we used our friends that we know within industry, and we put some phone calls in this morning before podcast and said, this is what we're reading. Is there anything else we need to know? And Robert Blum, the CEO of Cytokinetics, issued a statement. I'm just going to read what he wrote, and then I'm going to comment on it, or what he said. We remain confident in the distinct benefit, risk, and pharmacologic profile of aficamten and continue to expect a differentiated label and risk mitigation profile upon its potential approval by the FDA. So for those of you who have been around the block a few times with us and saw the Camzyos launch, or mavacamten was the drug name and Camzyos is the brand name, first-in-class myosin inhibitor, it had a really strict REMS program, risk evaluation mitigation system. And that required a lot of echocardiograms. And it was the first time the FDA put an echo requirement on a label. So it was groundbreaking. And now they've gone back just a couple of weeks ago and gotten a revised label that limits those echocardiograms and how often that they're needed for mavacamten, Camzyos. Now, Cytokinetics has got a PDUFA date for September, and there's probably going to be a REMS program on that drug too, because it's in the same class. But why a delay? We don't know anything else that's been published. I'm going to hypothesize for the next segment, and I will tell you when my hypothesis ends. There could be a couple things going on here. Number one, there's changes at the FDA. Are those impacting how fast we can move things? I don't know. Do they have any impact whatsoever? I don't know, but it's not out of the realm of possibility in the current day and age. Number two, they've just mitigated a mitigation system, and maybe they want to see what it looks like to have some real world data out of that trial before they stick a label that would then need another accommodation in a short period of time. So maybe by learning more off of the mavacamten Camzyos data on the mitigated REMS, that might inform the new label. So these are the two ways that I'm looking at it right now. Looking at the back end data of aficamten, I have no concerns whatsoever about the effectiveness that I've seen demonstrated in clinical trial after clinical trial. So I'm not worried about that. And in fact, some of the early data indicates that the drug does have effect in the non-obstructives. And we'll talk about the Odyssey trial in a minute with Dr. Ayers. So at this point, there is a delay on aficamten's label. So I'm going to give another hypothesis and observation. I'm not so concerned that it's going to really impact patients' access to the drug for a couple of reasons. Number one, anybody who's on Medicare, you don't want to start a drug in the fourth quarter. Then you're paying a copay and deductible, and then you got to pay a copay and deductible again in January. It's best to start a drug in January. So from a finance point of view, I don't think it's that big of a difference. From when it's actually going to be available, when a label becomes available, it doesn't show up in your drugstore the next day. There's an entire upturn of the entire process that has to happen. And that can take 30, 60, 90 days. So best case scenario, if it did hit the market in September, most people wouldn't be able to get access to it until January. So now if we're pushing it back to January, we also have a little bit more time to prepare for that. And it will be available in January. And hopefully we can have everything scaled up to the ability that we can. But you can't go and negotiate prices with insurance companies until you have a label. So there's just going to be some lag time. So we can really look at Heart Month as February of next year is probably when this would be available in the hands of patients, as long as it does get its approval. Michael, that's my hypothesis. I'm stopping hypothesizing at this moment. What do you think?
Well, as always, our hypotheses are pretty similar. I take that as a compliment to myself. You usually are right on the money with these. I guess if I was talking to a patient about this right now in the office, I would start with what I knew. And what I know about aficamten is that the drug is incredibly effective at making obstruction go away, at making your cardiac enzymes get better, at making you be able to exercise further, and at improving symptoms. We also know the drug is incredibly safe. Adverse events in these trials were very low. So, in the background of all of this, I know I've got a safe and effective therapy. What I would add as an aside to that is something that my wife constantly has to do for me. Don't always assume it's about you when there's a problem, right? So you hear something goes poorly and you go, oh, I must have done X, Y, Z. Oh, this must be because they didn't like me. Oh, this might have nothing to do with aficamten whatsoever. And so I think the first thing we have to admit to ourselves is we don't really know what this has to do with or not. We just know we have a safe, effective drug. If you made me play the hypothesis game, and I'm pretty risk averse, I'm a wimp, but I will do that with you. I'll play the hypothesis game. I think your hypotheses are very good. And if I was going to reflect back the 3 or 4 things I heard there, one, independent of your politics, with respect to your purple nails you've got on there, independent of your politics, this might be something that has to do with restructuring that's going on in the government now. And it doesn't matter which side of that debate you sit on, but this might have to do with the FDA. Again, nothing to do with aficamten at all. Possibility 1.
Yep.
Possibility 2, they did just redo MAVA, and maybe they want to look at that data set. I'd have a tough time with that if I was Cyto, because I've got a drug that had fewer adverse events, that's got a shorter half-life, meaning if there are adverse events, I'm able to turn it on off quicker. That's extraordinarily, all things being equal, comparable to the drug you already have on market. So for you to say, oh, we want to see the drug that's very, very similar to you, if anything, slightly riskier profile in some ways, more before we approve yours, I'd have a lot of tough time with that, but it's possible. The FDA has done stranger things. 3, I think it's possible that Cyto might have initiated some of this in wanting a differentiated REMS. The FDA might have said, hey, we just redid the REMS. Here, you get to use this REMS. And Cytokinetics might have come back and said, no. We need an even better REMS than that. And maybe this is on Cytokinetics' side. Would be a reasonable thing to explore, particularly given that most private practice cardiologists cite the REMS as one of the major reasons they're not using the drug. So we talked about government problems. We talked about the new REMS wanting to see more MAVA data. We talked about Cyto asking for a more favorable REMS. I guess I will also admit to you that cardiac myosin modulation is being looked at very closely after Edgewise's AFib data. And it's possible that they came back to Cytokinetics and said, we need to understand a little bit more about your atrial fibrillation rates on and off therapy. I would be pretty upset with that if I was Cyto as well, because I'd say you didn't make MAVA do that, right? And MAVA across the board through these trials has had slightly higher AFib rates than aficamten. Why are you doing this to us? To which the FDA can sort of say, yeah, but that horse is out of the proverbial barn at this point. I can't go back. This, I can be more circumspect. So those are my 4 hypotheses. Again, might not be about the drug at all. Got to keep that in mind. And again, this is a drug that's safe and effective, and that most of us out there in the community writing those are very excited about. So that's sort of my spiel, and now I'll be quiet.
So I think I have a message for a community that's probably not listening to Tales from the Heart, a podcast from the HCMA, because, maybe they're not listening. But maybe they'll get this soundbite. Stop being so scary, street people. And by the street, I mean the finance community. Something happens in a pharma company, and I'm not saying that they don't understand the constituency or the ecosystem all the time, but their focus is on immediate return of investment because they're into this for the finances. We're into it for the life saves and the improvements in quality of life. So our goals are different. They're synergistic, but they're different. And they read into things that don't exist and they make things up that aren't there. So I think there was unrealistic expectation from the street of how many people were going to start a myosin inhibitor in the first couple of years, as we've been a disease state that has been living off of generic drugs and making do with what we've had and operating in a very different ecosystem than a labeled indication drug allows us to live in and have the hope of better quality of life. We just kind of dealt with what we had. Now we can expect better quality of life because we've done all this work to create a technology that hits the target of why our hearts are screwed up. And 3 months in the long trail of HCM history that has started way before the first diagnosis in the United States in 1958, you can go back to why is a marathon a marathon? Because Philippides dropped dead at 26.2 miles. Why? Because the heart probably gave out. Did he have a normal heart? Maybe. Did he have an HCM heart? Who knows? But this is a biologic process that has existed for a long period of time. And here we are in a time of discovery where we can make people feel better. We can fix problems at a very deep level. Not get rid of them completely yet, but that's the goal. And it's like 3-month delay. Oh my goodness. 3 months in the history of humanity ain't bad. So we need the street to understand that you need patience here. And the patience that you have will help patients that we have. There's my message to the street. So other stuff is going on in medical management May. I will start with just the reflections of our Hill Day. If you have not watched the video of our Hill Day, it's about an hour and a half long presentation. There are different segments. You can go listen to different people's stories and why we were there. We went to the Hill on a very purple topic, multiple purple topics, honestly. And that is generic drug quality. What you're getting over the counter isn't what you think you're getting. And we need to make sure that people know how to know where their drugs are coming from and what the quality of that drug is. This is as purple of an issue as you can get. We all take generic drugs and we all want them to be safe and effective. So there is a process. I'm not going to belabor the whole Hill visit. You can go look at it online. We brought the world's experts to the Hill. We talked about the reasons why we're having problems, where they're coming from, and how to detect them, and how to keep people safe. That's the whole goal. Yes, it does say, let's manufacture more in the United States. Yes, it does say there are good generic drugs coming from India and China. And it also says there are bad generic drugs coming from India and China. And we need the ability to know who's who. So there's a system that's in place through the DoD that's inspecting these drugs and making those observations public to those who purchase large quantities of drugs like health systems, hospital systems, insurance companies, PBMs, et cetera. We want to give them the tools to be able to know what's good and bad. So if that ain't purple, ladies and gentlemen, I don't know what is. And we met with Democrats and Republicans, and they all said, we are in. We are in. And within days of our Hill visit, I heard talk coming out of the White House about generic drugs, and we really need to figure this out. So we made noise. We made good noise in a chaotic time. We also talked about, and I'm going to get a little spicy here just by my terms, but I think I'm going to surprise you with how I turn them. We talked about fraud, waste, and abuse perpetrated upon patients, health insurance or health providers, and physician offices. And that is through prior authorization processes that are absolutely arduous and unnecessary. They do nothing to protect patients, and they cost $1.3 billion a year, and they waste. It's nonsense. Prior authorization should be very specifically used for procedures that have often been associated with fraud. I just heard a piece today on social media that a particular inhaler, this is from an allergist, not cardiologist, but a particular inhaler is no longer available in name brand, and there's an authorized generic. But to get that authorized generic, you need to fail these other drugs, which actually have different chemical compounds completely and work on a different root cause mechanism. But they're getting automatic denials on the refills to authorize generic because they didn't go through step therapy. Why are insurance companies practicing medicine without license? Why are we allowing this to happen? I don't care who you voted for or what your political beliefs are. When the hell did the insurance companies become the doctors and have no recourse? So come on. These are the issues we're going to the Hill with. And I do need to address something, as Michael, and then we're going to go into the other drug discoveries in this space. You're going to start seeing more emails from the HCMA about using your voice to communicate with your elected officials about matters of importance to those with chronic illness, HCM specifically, but our global chronic illness community more wholly. I am not asking anybody to sign up for some right or left wing ideology. You can be who you want to be. These are important issues to our community, and we want you to have a voice. We know what we think is best for HCM patients and families and physicians that are caring for them because we're in the center of this ecosystem. We need to communicate that to our elected officials. Your elected officials do have a say in what you're doing with your health care on the federal and on the state level. Your voice matters where the future of your healthcare is going to be. And if they don't understand the problems that we're facing, they're not going to work to solve them. Our job is to put you in front of those lawmakers and say, this is stuff that my family's dealing with. Can you help me with these issues, like getting my medications at a reasonable price, having access to a specialist who actually understands my disease? Can you get me safe generic drugs? Can you keep my access to health insurance and my doctors? This is what I need as somebody who lives in this country. And that's what we're doing. I got an email back from somebody criticizing what we were sending out in our U-Join. I want to address it. I always want to address your concerns. They wondered why we didn't do it before. I didn't have the systems. I didn't have the team. I didn't have the ability to get an organized message through a system out to you effectively. And the system allows you to personalize it. We're not asking you to sign on to a letter and agree to everything. You can go in and edit it. You can send a video clip to your elected official saying, this is what I believe. This organization said this, but I want to add on this. Your voice is always what matters. And I will just remind you of a couple of very small words. We, the people. Go talk up. And we're going to give you that platform to do so. So I will drop my soapbox down now. And there's other new drugs coming in HCM. And we are in trial time. So let's start with the one that we're working on here at HCMA. And some of you answered a survey, and we're going to get back to you with a follow-up survey probably early next week so that we can relaunch this project, which had some technical issues on our side that we had to get over, but they're done now. So this is the lexicon trial. And I know that Dr. Ayers is going to be one of the sites for this trial, effective about 2 hours ago. So do you want to talk a little bit about Sonata HCM?
Yeah, so this is an exciting trial, mostly because those of us in the cardiac space have noticed that these SGLT2 inhibitors and SGLT1/2 inhibitors seem to work in just a number of different disease states. And so with that alone, we're pretty excited about the trial moving forward in hypertrophic cardiomyopathy. And then I think beyond that, what you're seeing, particularly in light of Odyssey, which I'm sure we'll talk about in a minute, this is still a space where we don't have evidence-based therapies. We don't have evidence-based therapies for non-obstructive HCM. And so we've got an exciting drug, an exciting mechanism of action, and we've got a disease subspace where there is no evidence-based therapy. And so I'm really excited about Sonata, about sotagliflozin in this trial. I think Charlene Day, the PI, is just a really brilliant physician scientist. I'm excited about her leadership. I will mention to you as a secondary comment that it is a potentially difficult trial to enroll because Jardiance and Farxiga, empagliflozin, and dapagliflozin have so many proven indications that a lot of my HCM patients with symptomatic non-obstructive HCM are already on these therapies. And I suspect they've derived symptomatic benefit from these therapies. And so it's always difficult as a provider to say, all right, Lisa's here in my office. Am I going to take her off medicine that makes her feel better in order to enroll her in a trial? Now, some of my patients, when I walk them through the fact that we don't have evidence yet that this works, are very excited in participating in the scientific process, kind of quote unquote. They want to be part of trials. They want to feel like they're contributing. But a lot of other people, and I don't blame them for this, I very well might have this emotional response, go, man, I feel so much better on this drug. You want me to come off this drug to get randomized into a trial where I might not be on a similar drug? And so there might be some problems with enrollment is all I'm pointing out. But it's an important trial. We need data that shows that it works. And there are a bunch of people who are excited about it. And there's a bunch of people who don't have an indication for SGLT2 inhibitors already, even though this is a 1-2 inhibitor. And so I'm expecting that they're going to want to partake in the trial.
I agree completely. And, full disclosure, HCMA is under contract with Lexicon to assist with recruitment. And what that means is we have provided a webinar. It was placed back in January. It's available on our YouTube channel. We're going to be republishing it and pushing it out again. We start with a webinar. We do a survey. We send the survey to anybody who wants it, who has participated in the webinar, because we want you to have some base knowledge. And then you can say if you're interested in talking to a site coordinator about potential participation. You can choose a site, and then you can authorize HCMA to send that information to a site coordinator who is then supposed to get back to you. And then we launch this. We're going to relaunch it because there was a technical glitch, and all those people are going to get a new survey, hopefully next week, that will re-engage them with those centers. And if there's not enough referrals, we will open up the referral pathway again. So it is an effective way to let people who are interested and educated get access and jump right into a trial and hopefully participate, or have the conversation and decide this isn't for me right now because of X, Y, and Z. All we ask you to do is listen to the webinar, complete the survey if you feel it's right for you to have the conversation. And after that conversation, participate or don't participate, but take our gratitude, because just having the conversation is a big step. So please just keep your mind open to this and other trials as they come up and find the right one for you. Now, we also did not disqualify up front anybody who was already on this class of medication. We're actually going to make it a little bit easier, and those people will technically be eligible, but we're not going to go for them as the first hit.
Yeah.
Because why stop a drug that you're already on? Like, that doesn't kind of make sense. So let's find those people who don't quite qualify right now, because it probably does have a wider indication. And like many things in science, as we were kind of talking about a little earlier, you don't know what you know until you know it.
Right.
And we're seeing signals, and hypothetically, it does appear that this mechanism will positively impact cardiac function in other people than those who already have a label. Sound reasonable?
Yeah, totally. The other thing I'll mention is if you're someone out there that screen failed, meaning you wanted to enroll but were unable, to Odyssey or Acacia, the most common reason that you screen failed, that you tried to enroll and were unable to, was your BNP wasn't high enough. And this is a trial where that is not an inclusion criteria. And so I have a good swath of people that were very motivated, non-obstructive HCMers. And now they're going to be eligible for Sonata. And so we're hoping to scoop some of them up. And it didn't, just to be clear for anyone listening, there is an obstructive arm as well in this. So you don't have to be non-obstructive. I just focused on that as an area of excitement.
It is. And let's stay on the excitement, and then we'll go to the disappointment part of the conversation. If that isn't a teaser to hang on for a few more minutes, I don't know what is. So we've got another trial that's going to be ramping up late this summer, and that's with somebody you may have heard of before here at the HCMA, and that's Imbria. You want to talk a little bit about the embryo trial and what that's all about?
Yeah, we're talking about Marty's trial, correct?
We're talking about Marty Maron's trial, yeah.
Yeah, so Dr. Marin has really sold me on this the last few times I've talked to him, again in the non-obstructive space. There's a trial called Fortitude that's going to be looking at a cardiac mitotropic agent. It just changes the way that your body handles different metabolic substrates. It changes the way that it processes fats and sugars. And the nirafaxstat is a drug that we're quite hopeful is going to be successful in the non-obstructive land as well. They used a creative endpoint in their phase 2 trial. So we're going to go a little down the rabbit hole. All right. So if you're not with me right now, this might be time for your coffee break, but I'll walk you through it if not. We've been very focused on VO2, which is a way of saying how much blood can your heart pump over a given minute. That's not the only thing that VO2 measures, but that's what most cardiologists are thinking about when they hear VO2. The problem with VO2 as an endpoint is many patients with HCM are also on a beta blocker. And how much blood your heart pumps is made up of two things: how much is pumped with each pump, and how many times it pumps a minute, right? So how much is pushed out and how many times it's pumping per minute. Beta blockers cap, they limit, they put a lid on how many times you can beat per minute. And so there's worry in the HCM community that measuring VO2 alone is a little bit tricky because you're potentially diminishing the effect of drug or our ability to measure the effect of the drug by keeping patients on beta blockers, which prevents their heart rate from picking up. And there's been some real truth to that in different trials where we think these drugs potentially were effective, but we didn't see the VO2 increases, and it's because the heart rate was so limited. What we looked at in phase 2 and what I believe they're also going to be looking at in phase 3 is something called, okay, bear with me, ventilatory efficiency. What that means is we normally breathe to push out carbon dioxide, and the amount of air we're breathing in and out is pretty closely linked to how much carbon dioxide we're pushing off. We know that bad ventilatory efficiency, I'm breathing a lot, but not a lot of it is CO2, is a big negative prognosticator in HCM. What Dr. Marin looked at in phase 2, which was really clever, was rather than focusing on VO2, he looked at improvements in ventilatory efficiency, which we know are tied with real hard clinical outcomes. So I'm excited about how they're tackling the cardiopulmonary exercise test component endpoint for Fortitude. And I'm excited again because non-obstructive HCM, we don't have evidence-based therapies yet.
Okay. So we will address Edgewise has been questioned in the stream here. We're going to do that one in a minute, but I want to move over to Odyssey. A little bit more of a complicated story. This time I'm going to start with hypothesis that is not scientifically bound. However, I know things. I've seen things. I know people who have been on drugs for a long period of time. Lisa's hypothesis, I think our endpoints, what they used to measure in Odyssey, were off target. Non-obstructive HCM. Okay, so I come from personal experience of having obstructive, non-obstructive, and no HCM. So there are only a handful of people who have this lived experience, knowing the difference between being obstructed and non-obstructed and what a normal or as normal as a transplanted heart can be, what it's supposed to feel like. I do not believe we as an entire ecosystem have done enough, and I take blame for this as well, to define the burdens of the non-obstructive patient specifically enough to build the better endpoints to see what success looks like in that group. I don't think we've done the work to figure out who these people are and what we can do to actually improve that heart. And we're learning as we go. With all due respect to everybody who was involved in Odyssey, all good people, all with the right intentions, I don't think the world did enough research on non-obstructive HCM to be able to identify those better endpoints. And here is my why. When you have obstruction that septum is meeting that wall, the blood's not getting out, we have obvious symptoms from pressure. When we get rid of that, people feel so much better. And it's light switchy kind of stuff. And when it happens, it hits us hard. When it goes away, we feel relief. But the underlying functioning of that heart muscle is not normal, but we think it's normal. So defining normality and symptoms becomes very, very difficult in the non-obstructive population. And the subtlety of the progression is so slow that a 48-week trial, what did we really expect to see change positively or negatively in such a short window, in such a long life? So I think the endpoints weren't great. And hey, Street, if you're listening, I still think there's value of mavacamten in the non-obstructed population. Just saying. So I think that there's a potential label down the road for them, but I think they need to refine their endpoints better. And why do I make these statements? I helped recruit patients into Maverick. That's not a name most people remember in HCM. It was one of the first trials in myocardia. First, we did Explorer. And then as we were getting ready to launch Explorer and I was going to help them do recruitment for that trial as well, they're like, oh my God, could you do Maverick too? And looking back, the non-obstructives kind of feel like the add-on. And we'll do those. But I don't think the depth of understanding of the disease process was there then. And I don't think it's here now to design great trials for non-obstructive HCM. Michael, what do you think of my hypothesis?
Oh, as usual, I think it's spot on. I think there are two primary issues with Odyssey. I think the first is exactly what you said, an inherent problem of endpoints in clinical trials for non-obstructive groups. Obstructive groups are like a trial designer's dream. The gradient was high, the gradient is low. Look at my number, look at my, right? Like I did it.
Yes.
Non-obstructives, much, much more difficult to find endpoints. Now, some of you might be thinking, why don't you just use hard endpoints? You'll hear us referred to as hard endpoints or clinical endpoints like hospitalizations, death, transplant, ventricular tachycardia, etc. And the problem is, luckily, in modern therapy, for the most part, those are relatively rare. And so in order to run a trial powered to look for those, you'd have to have a massive trial, tenfold bigger than what you're seeing right now. And so the endpoints is the first issue. I will add a second issue, and I say this with just the utmost respect for Doctors Desai and Owens, who were in charge of this trial.
Again, yes.
Just superstar clinicians. But this was a trial that enrolled very fast in a bunch of sites. And whenever you see that happen, particularly in rare disease states, your worry is that you get heterogeneity of the population being studied, meaning not everybody really had non-obstructive HCM. You worry, are there some hypertensive cardiomyopathies that slid in there? Is there an amyloid patient or two that slid in there? Did I really select for sick non-obstructive HCM patients that were going to benefit from my drug and show benefit in the end results? Or did I get them plus some other folks that maybe don't derive the same benefit out of CMI? And then what happens is the benefit gets watered down, right? You don't taste sweet tea, you taste half sweet tea and half water, and it's a little bit bland and you can't tell the difference. So that's my other worry in the trial. I think if I was in the investor space, I would say be patient. Wait until we see exploratory endpoints in subgroups. Because my guess is when you start looking at genotype positive patients that you know have HCM, or patients with thicker heart muscles at baseline, which are much more likely to be HCM rather than hypertensive cardiomyopathy, what you're going to see is some signals come out. So exploratory subsets, exploratory endpoints. I still believe this drug works in non-obstructive HCM. But endpoints are tough, and I'm worried about heterogeneity of the enrolled population.
I'm not as concerned about that because of the sites that chose. I think they would have figured out the mimickers. Some of the smaller sites that don't have big HCM programs, I would want to dig into their diagnostics a little bit more. But looking at peak VO2 and KCCQ, regular KCCQ in the non-obstructeds, we're developing a KCCQ HCM that's being validated right now. If that's being validated, maybe we'll have a better PRO. I have something else that I can talk about at the end if we have a minute about maybe a different PRO, a different perspective from the patients that might actually turn into a real tool. But for those who aren't following, and Ross, if you could drop the press release about Odyssey and what they found, that would be really helpful now. So what happened is Odyssey didn't meet its primary endpoints, which is why I started my rant with, I don't think they picked the right endpoints. Some of the secondary endpoints potentially have meaningful data in them, but we haven't seen those yet. So we're waiting to see if any of the secondary endpoints are strong enough to consider having maybe additional trials in the populations that seem to be responding to understand why they seem to be responding. And I am really encouraging all my friends in this space at BMS and at Cyto and at Edgewise and all the other companies that are in our drug discovery space to really take a deep look here. Like take a global pause and say, do we understand non-obstructive HCM well enough? What do we need to understand it more? And what are our expectations with current technology and burden of disease? How do we scale them together to limit the burden of disease and to improve quality of life while providing an efficacious, cost-effective mechanism to do that? It doesn't happen in a silo. This is why it's really important that we're all talking together and we're all coming together on these decision-making processes that impact policy, research, academic medicine, clinical medicine, health insurance, advocacy. It's all of us doing this together. So there's a particular handful of people that I know that I recruited early into Maverick, mostly because it looked like they were heading into transplant and there was nothing stopping them. And obviously, transplant is good for some, but as you heard at the start of this particular episode, it's challenging and it's not forever for everybody. And you're better off sticking with the one you were born with if you can do that. How do we make that happen as long as possible for people? Well, there was this group of people that I said, go into this Maverick study. That was 2018. It's 2025. They still have their hearts. And they had every other clinical indication that they were heading to transplant. 5% of us will be that. Is this meant for that 5%? Is that all that's going to benefit in the non-obstructed? I'd find that very difficult to believe. That obstructed can benefit and end stage can benefit, but that middle of the road can't. So maybe we're just looking at this a little wrong. And I think if we all come together and really look at the data from the patient perspective and what we actually live, and we talk to the scientists about what the actual mechanism is, we can find a way. And I do believe the data is going to show. Boom. So Emma just gave a shout out to Dr. Ayers as Lisa dropped that next mic. So that's Odyssey. What else do we need to know about Odyssey?
We don't know what BMS is going to do next in the non-obstructive space. I think they're still circling the wagons. I'm hopeful they're going to look in the non-obstructive space ongoing with MAVA, but we don't know. So that's a TBD out there. We'll see.
We will see. Some sites have already been telling their patients that they're closing down the trial. I haven't got a 100% official that that's what's going to happen across the board. They're waiting and they're looking. So I still think there's a there. I don't know how big the there is.
Yeah.
I don't know if it's worth $100,000 a year there, or maybe it's worth more if it stops somebody from needing a transplant.
Yeah. And Acacia is still ongoing. While it is a slightly different mechanism of action, aficamten versus mavacamten, they are much more alike than they are dissimilar. Acacia enrolled with a different set of inclusion criteria. They enrolled at fewer sites. They enrolled a little bit slower, so they might have a more homogenous population. We will see. I'm really hopeful that there's a there, and we'll see how aficamten moves forward.
So we jumped from BMS to cyto again. So acacia, anything that sounds like a tree is cytokinetics.
That's right.
That's pretty much the easiest way to understand who's doing what trial. So last but not least in the drug discovery space, because we have a couple other ones, but the Edgewise. You want to talk about Edgewise?
Yeah, Edgewise is very exciting. It's a drug that has a distinctly different mechanism of action. My guess is it's doing something to modulate the head of myosin. So myosin kind of looks like a hammer. And my guess is it's doing something that's modifying the myosin head. I say, I guess, because if anyone from Edgewise out there is listening, you can chuckle to know that none of us know how your drug works still. We'd love to know. But rather than inhibiting or turning off the myosin head, it's probably changing the conformation. And that's important because that subtle distinction of turning off versus modifying means that you likely need a lot more of the drug in order to see people drop their ejection fraction below 50%. And that's certainly what their phase 1 data looks like. That small difference in mechanism of action makes it much less likely that your heart function drops below 50%. I'm very optimistic. I'm very bullish on this drug. This drug got beaten up in the press a little bit because there was some atrial fibrillation rates in the phase 1 data. I think they had 4 patients, of whom 2 they later said we're not sure had HCM. And they paused their trial to kind of recalibrate and figure out how they wanted to move forward. I'm still very optimistic in this drug. I think that the AFib story is very complicated. We could spend a whole hour on that in and of itself. But I'm pretty optimistic about the EDG 7500, which I'm also looking forward to getting a name because that's just a mouthful to say. And yeah, I'll stop there.
Yeah, the names are always, they take me a little while. Some of them are like different languages, and I'm not really good with language skills. So there you go. I think Edgewise being a not third in class, but next generation myosin drug.
Modulator, yeah.
Myosin inhibitor, deactivator, calmer downer, whatever we're going to call it. One of the explanations that was given to me from the Edgewise team was the concept of a myosin inhibitor works on the push and the pull, where Edgewise is really only working on the release.
Yeah.
So if the myosin head is getting drugged during the entire process, they're saying that they're really kind of hitting it in the relaxation phase, so it's more effectively relaxing. Very layman's terms. So,
yeah, sometimes I talk about it with my patients as cardiac myosin inhibitors. Imagine you got 100 people in a longboat. Myosin inhibitors are saying 50 of you, put your oar back in the boat. Stop rowing. You're off. What myosin modulation is doing is it's saying, all right, everyone keep your oars in the water, but instead of going 2 feet deep, go 1.5 feet deep. So it's modifying how everyone is moving rather than turning some on or off. Seems like a subtle distinction, but boat A is much more likely to slow down dramatically than boat B, which is going to see slower changes in speed. Boat A is much more likely to have EF drops, ejection fraction drops, than boat B.
It appears to be a more controlled way to regulate myosin activity.
Yep.
Yeah. But we don't know yet. So Vicky is asking time frame for restart. Can you, she participated in phase 2. So Edgewise is currently in phase 2, and they're going to be continuing in phase 2.
Correct.
So if you were in that trial, your trial time is probably completed. And if you're still active in it, then you're still active in it. Okay. So one more drug to talk about as we hit the top of the hour, or company, and that is our friends over at Haya, who are working on something called Whisper technology. Want to talk a little bit about Haya and Whisper Tech?
Well, most of what I know about their tech comes from my conversations with you. I'm still due to meet with the company. They've been very whispery back and forth with me about telling me how the drug works. They've got my understanding is at this point, they've got some compelling data that suggests it does work. They have a mechanism of action that they're starting to understand that they think really targets something in the pathogenesis or origin of this problem. But this is more of another to be determined on my end. I have a meeting scheduled with them, so hopefully soon, thanks to you, Lisa. So thank you.
So, what they're working on is something that they're kind of classifying as an antifibrotic. So, they have created a technology in which stops the heart from creating scar. And I don't fully understand all the mechanism myself at this time, but I have been talking to them since 2018. So while it's a name that I'm just bringing up for maybe the first time in a podcast, Haya, Haya, they've been doing quiet work for a long time. I met with them when I was in Switzerland a couple of years ago. They were moving forward. They're a small company, but they are a smart company and they've got some real interesting technology. So stay tuned for that. So while we go through this wild ride of drug discovery and also ensuring that the drugs we already have are safe and effective. So we have our generic drugs that are our base that we live off of, every one of us. We need to make sure that they're safe, but we need to keep creating new drugs through complicated times. Just because there's going to be changes in process doesn't mean they're all going to have to be polarizingly difficult. We're going to have conversations. What is the most effective way to do the work that we need to
Yeah.
do? We're not going to say we're not doing the work. We know this work is important. We know people's lives depend upon this work. So we are going to do the work. We are going to do drug investigation. We are going to do clinical trials. How do we do that effectively? How do we make the people pay for the process that are using the process? So those are user fees that companies pay the FDA, which some people currently don't understand. They think that the company is literally paying Michael Ayers to do the work for me, and that way I pay Michael, so Michael reports to me, the company, not FDA, his employer. So no, that's not the way it works, and I'm just giving that as a hypothesis for anybody who tries to clip this later. Michael does not work for a company. He works for a medical institution. So if the company is not paying a user fee to process the application, who's paying for the processing of the application? The taxpayers? I don't think that's fair. I don't think that's right. And a lot of people would agree with me that I shouldn't have to pay my personal taxes to develop a drug that I'm never going to profit from and I'm never going to see the benefit of. So the companies who are making the drug that will sell it for a profit, that will make money off of it later, because that's the way the system works, should pay the fees up front. They should go to the front end of the FDA, and the people who are working on a project should have absolutely no connection with the financial relationships between the drug company and the FDA. But somebody's got to pay for them to sit there and do the job. And it can't just be somebody off the street who has an interest in drug discovery, but doesn't have the proper credentials to do the work. So we need to make sure that we have scientists who understand the pharmacological aspects, the physiologic aspects, the regulatory process, like all the things. Those people are not inexpensive. They are skilled, trained professionals with knowledge that you need to keep you safe. And that's what the user fees pay for. So we're not going to pay for it through that. And we're not going to change our entire scope of how we do healthcare and not let drug companies make money off the drugs that they're developing. Like, if they're not going to get money off of it, who's going to make the drugs? Like, you can't have it both ways.
Yeah.
You can't have a utopian society where the perfect drugs just fall out of the sky and poof, we know that they're good. It's hard work and process. Michael, what do you think about that?
Oh, I just could listen to you talk about this stuff all day. We're very lucky to have you advocating on both sides of the aisle. Sometimes doctors really fail to think about the policy ramifications of these things, and we get very siloed. And it's refreshing to see somebody taking a 30,000 foot view, if not even higher. So thank you for doing that.
Well, thank you for being part of this really incredible ecosystem and to have everybody understand the true roles of all of the different players that make medicine happen. Doctors and their offices kind of get a bad rap sometimes because it took me so long to get in and I had to wait and the insurance company did this and there was this barrier and that barrier. A lot of those barriers don't have to be there. We could get those appointments in faster if your staff isn't wasting their time on prior auths and step therapy and bleh, nonsense. There are ways that we can do surveillance through technology that the insurance company doesn't have to ask you a million questions, but they still are asking you to send paper files for verifications in some cases. Do we need to send paper files in 2025 to an insurance company to approve a medicine? I don't think so. So why are we allowing that? So we all have to talk about it. And that's, my friends, is all that's going on this week at the HCMA. You're going to be getting, some of you are going to be getting some surveys for some opportunities coming up. If you get them, please act quickly because these are limited time opportunities. So if you've told us you want to volunteer, you're probably going to be getting some communication in the next 2 to 3 days. Michael, thank you so much for joining us. Is there anything else we need to know going on at UVA before we part today?
We got a lot of trials. We got a lot of patients. We're hiring new providers. We're getting James McNamara from Southwestern. We have a new APP. It's an exciting time. Come visit us. Lisa, I'm going to hop off onto an NIH call about HCM. It was
Good
very
luck.
nice
Send my love.
I will. I'm sure they'll ask about you.
Thank you. Bye-bye.